Hello, my name is Albert Merati, and it's my great privilege to be here to speak to you, congregated here virtually as part of this year's ACA. I'm sorry I couldn't be there in person. I know I was very privileged and happy to be invited for last year, but I'm glad you kept the date, so to speak. I am here in Seattle. I'm a professor at the University of Washington, and I'm an otolaryngologist. I appreciate that this talk is going out to our colleagues in otolaryngology and in ophthalmology, two historically related organizations, obviously, who've really diverged a fair bit. But I'm hoping that many of the themes that we talk about, not just personal and related to our choices in our careers, but also some of the more general things affecting us in subspecialty medicine or specialty medicine. I hope they resonate, period. I hope I'm not off base. Um, like I said, I'm here in Seattle. I don't have any financial disclosures relevant to this talk. A couple of the sources which will be quoted here and there, I'm happy to send them out. I can't lie, the first two are great books. From what I hear, I mostly know them from the TED Talks, but they are really terrific. I have also some reference material for the third book as well. Despite these important, particularly the first one, important references for this presentation, um, really it's mostly very personal. Plus some lessons learned during my time in otolaryngology leadership. As may have been part of the introduction, I'm one of the past presidents of our American Academy of Otolaryngology, our big subspecialty organization with now 13,000 members. We've just topped 13,000. And as well as being president of the American Bronchoesophageal Association and being involved in lots of things. That's part of the magic and maybe part of the pathology we're going to talk about a little bit. Why do we do these things? Is this role in leadership, is it about me or is it about you? What am I doing? Why are we doing all this? So we'll talk about that. So the objectives I have in mind are to discuss the role of self-understanding and career planning. Who are we, right? I mean, why do we do the things we do? I want to talk briefly about the emphasis to emphasize the value of the personal mission statement. And I realize lots of people listening to this are early in their career, students and trainees and folks in their first few years, and that's great. I hope this will land on them. I imagine there are folks, of course, like any talk, people with various degrees of history and accomplishment and where they are, but maybe it's time for a revisit to this for somebody who's well into their career. I don't know that for sure, but I hope there's value to this as we all learn and grow how to be mentors and sponsors and leaders in our communities, whether we're in a private practice in Schenectady or in a teaching role in a medium-sized city in the Midwest. I mean, whatever it is, there's always an opportunity to sharpen our skills and really clarify and purify, our the things we're doing with our communities. So whatever circles those may be, even though it doesn't precisely fit the talk title about leadership, with my perspective, I've had a front row seat of some of the deliberations, a few fights um, regarding the trends and directions in specialty medicine. I will bring up some of these as they relate to payment and technology and representation within our fields. And then talk about the personal price and the cost for career choices we all make. And so everyone's got their own thing, right? I mean, we can't always see the struggle in the person across from us or in our patients for that matter. Some are more obvious than others, but there are reasons why people do the things they do. And I think there's a reckoning for these things in our professional lives. We'll talk about that. So here's a good example. So I'm an old man with young kids. I'm 55. I just turned 55. And this is a picture a couple of years ago at Crater Lake, where my kids, who are now 11 and 7, who they're getting their ranger badges at Crater Lake. And then on a walk somewhere, I think in Eastern Oregon, kind of a remote area, checking out some fossils. So that's really important to me. These are the things that are magic to me in my life. But all the things we talk about professionally, whether or not it's a personal advancement, chasing clinical activity, I don't mean chasing, but pursuing clinical activity, remaining busy, and then all the organizational stuff that we find ourselves involved in locally, regionally, nationally, et cetera. There's a reckoning for all of this. And, one of the things I like to say is that, every yes at work is some sort of a no at home. And that's not unique to ophthalmology or otolaryngology, but it is important as we talk about these plans. There are really vanishingly few, and I'm sorry to say this, vanishingly few folks who, for what it's worth, are in leadership in our field anyway, that that I've come across that really have had a smooth path or a really wholly successful path in their personal lives. It's not unique to being a physician or an otolaryngologist or an ophthalmologist, but um, maybe it's too high of a bar, but to imagine this for ourselves. But there is a price to pay for these things. We'll talk about that a little bit. We'll get down to the nitty gritty too. Well, it's obligatory. I have to show a Who album in every talk at some point. This is, their last sort of the core group in '78. They released the record "Who Are You," and I think this was an important thing. And I thought I knew it, or maybe I inherently knew who I was, but I didn't know how it was affecting my decisions and and why I did what I did. And I was pretty clear about what I wanted to do, but I didn't quite know why I wanted to do it until later in life, and that's okay. But I want to talk about this journey a little bit as you look at your own, as I encourage you to look at your own, where you are in your careers. I mean, what is it you're doing? Am I in the, are you in the situation you want to be in? What lies ahead? What does 2025, 2030 look like? All that. I never thought I'd be the president of our academy. Sweet Jesus. I mean, that was for really famous, accomplished people. I achieved some notoriety in my teeny little part of otolaryngology. I just do laryngology, like Dr. Madden. Um, and it's a teeny part of our field. But it these connections I made through the years really got me more and more involved and engaged, and I found myself on this path and the track to. I mean, it was an election. I had to run and get elected to be the president of our largest world's organization, world's largest organization of laryngology. It's a bit of a. I mean, you're not exactly driving the boat around for a year. You're a little bit of the grand marshal and the hood ornament, but you are involved in every decision that gets made substantial, whether it has to do with specific policy things, legislative things, collaboration with our colleagues from all different organizations. Usually positive interactions, some combative. That's okay. So it really did put me in a good position to maybe really pursue and scratch some of the itches that I had always wanted to do. And that's why I pursued these things. But again, there was a price to pay for all this. But it's something I ever imagined. So when we look at our careers, one thing I did relatively early, I think I was a resident, maybe I was a fellow. I wrote out what I wanted to do with my professional life. It's a super simple thing to do, right? 2 paragraphs, 1 paragraph, 2 lines. I don't know. And many of you have done it, but many of you haven't. I'm not wagging my finger at anybody. I mean, I got all kinds of mistakes and faults and problems. So I'm not better than anybody, but this helped me. And I bet it helps most of us. So I encourage you to do that. What is it that you see for yourself? What is it you want to do? What is it you want to accomplish? And in what way? And we'll talk a little bit about the way, the why, the who, the wow, the who, what, and why, and all that in just a minute. I think this is really important because when we face decisions, when we're asked to do things, or when we're confronted with options or opportunities are brought to us, we have to think, am I on mission? Am I getting where I want to go? Is this a distraction? Is it going to deter me? Right? You can't just walk around your early career saying no to everything because it doesn't exactly vector up with your mission. But if you keep this in mind and commit to it, I think it'll help. Now, it's not immutable, right? It's not concrete. You can change it, but I think it's helpful to have this. I really want to encourage, especially our early career folks, to do that. So who are you? Just like the record, who are you and what do you want your life to look like in the future? For me, I had a very privileged life, to be frank. I mean, I was, my father was an anesthesiologist. He's a retired anesthesiologist. in a very supportive, home, and lots of push, not a lot of, I describe my family life as all propeller, no rudder. Um, but typical sort of immigrant life. And for me, it was, just the ideas. I looked to the forward. I knew I needed to do something. And what was it that I would do? Turns out I was very lucky. I liked medicine, and it was good to me, and I was pretty good at it. But within otolaryngology in particular, I really fell in love with the idea of being, in the old days, they used to call this the essential number two. People who weren't necessarily the chairperson, but they had their own little fiefdom within a practice or within academic practice, because that's mostly what I knew. I wanted a busy, complex practice. I wanted to be the center of attention. I didn't want to take it from other people, but I wanted it to be about my vision, and that's a selfish thing, and that's a bit of I wonder if it took that little bit of ferocity to defend that vision to be successful. I don't know. I hope I wasn't successful in whatever degree I was by putting down or hurting other people. I don't think I was, but I didn't want anybody else to put me down or get in front of me. So I just tried to stay positive on those things the best I could. There was a famous otolaryngologist many have heard of, Charlie Cummings, was my chair when I was a medical student. When I was in fellowship, Jim Netterville was at Vanderbilt. I was Dr. Ossoff's fellow. He was a big, powerful guy, and I learned a lot from him. But when I did clinic with him, it was big, and it was a big team, and they're making decisions, and it was all appealed to me, right? And then Netterville too, he really had that. And I wanted to impact other people's careers and build bridges and programs, and the ingredients were communication, being good about communication. I like giving advice. I mean, what advice? Who was asking me for advice, right, for years? But now I get asked advice. I think I'm okay at it. And expertise, you have to be a content expert. You just can't be a leader about leadership, I think. There are people who are really good at process, and that is their expertise. But fundamentally, as physicians, whether we're ophthalmologists, otolaryngologists, or fill in the blank, people have credibility when they're good at what they do clinically, right? Intramurally, particularly, right? If you're a physician practicing in a medical environment, whether it's your clinic, your medical center, your community, being really good at it helps your legitimacy when you're doing organizational things. Whether it should or shouldn't be, I don't know. Being a great physician doesn't make you a great organizer or leader. Understood. But boy, it sure is a ticket into those opportunities. So, having expertise and skill really helps in that regard. And how do you get there, right? And so, every decision I made, trying to figure out, well, what was I going to do with my life, really was about pursuing that vision. And so, it isn't. My story isn't everybody's story. I recognize that, but those are the things that helped me. Years later, I came across this TED Talk. It turns out it's a book by Simon Sinek called Start With Why. And many of you perhaps are familiar with this. And I think this came to me late, but it helped me understand just what it is that, why I do what I do, or at least to understand the meaning or the importance of understanding why I do what I do. Let me go back to that. I went too far. Looks like I can't go back, but when we go back to when we imagine that start with why, on the outside we have this what we do, right? And that's being a specialty physician. So in my case, I'm a otolaryngologist, and in many of the cases, otolaryngology ophthalmologists, that's what people see. Or more specifically, I happen to be a laryngologist. Someone out there does retinal surgery, for example. Whatever your identity is, general or comprehensive ophthalmology, whatever it is, that's the what, right? That's what people see. That's what's on your shingle. That's what's on your card. How you do what you do is quite variable. And this is interesting. You have people, everybody has these colleagues who are really good at certain aspects, right? So for me, it's about communication and a little bit of cajoling and getting people to convene, right? I'm the convener personality to some degree. Some people are very quiet and reserved, and they do their best by like a ferocious attention to detail and focusing on the process aspect. That's their how. So the outside is that what, and then the how. But I think the thing that's important to understand about ourselves is why we do what we do. And it wasn't until years later that when I thought, geez, am I just into all this stuff because, it's for my ego, or, that's probably not untrue. But for me, it was the desire, not just not to be left out, but to avoid that. But I really wanted it to be up to me whether or not I was involved in something. If I looked in the distance and saw, oh, look at that group, I wanted to have the ticket to be in part of that, whether or not I got involved, right? I wanted it to be my choice. Now that's a substantial delusion, right? That I have any kind of actual control over this. But but that was what really compelled me. I recognized years later I wanted to be involved. Now what went wrong in my childhood to drive that? It's a different story. But well, maybe it's not a different story, but I won't go further into that. But I really like that idea of that's what drove me. Now, if you're the center of your circle, the why is that you want to be a community expert in, I mentioned retinal surgery. If you're in a medium-sized city and you want to help tie the community together and improve the healthcare of people, that's because you like that feeling of when you're in the grocery store and you run into somebody, or a gift you get, or you get paid. I mean, I like getting paid. Whatever combination of things you do, understanding why you do helps, I think, help me make decisions, and recognize the choices I make in leadership in particular. What power do we have? Well, there's, in clinical medicine, there's yes and no, basically, and you get rewarded, generally speaking, for yes, but you have to use no every now and then. And one of my great professors, Gail Woodson, really a pioneer laryngologist, and actually another president of the academy, taught me early on the V to E ratio, and that's it's a little calculating, but it's the visibility to effort ratio. And that was an important construct for me when I was making decisions early on. When somebody's asked me to do something, what am I getting out of it? But really, how visible is it, and how much effort is it? I didn't mind doing things that had intrinsic value. In the academic chase, right? It's writing a book chapter. I mean, I learned something, but it wasn't very visible, and it was a whole lot of effort. Picking things that had a better visibility to effort ratio, or having a blend of things so you're not stuck on one end of the VD spectrum, is pretty important. You can't really choose the people you end up training with that much specifically. With some exception, I was able to choose Dr. Osthoff as my fellowship mentor. I had fantastic people around me. Dr. Bodine, who I did my research with, Ernie Weimiller, Bob Toohill, Charlie Cummings, and Lisa Orloff, all these wonderful people. I was lucky. Everybody's got folks in their corner. And if you're not sure, they may need a little activation to get them interested or engaged, or recognizing that they need to help you or need to be involved. So don't be shy of reaching out for help. When you're going through your career, I mean, we're none of us are volunteers, or at least most of us aren't. Why does anybody want to hire you? I ask this for myself. Now I'm in the position to be involved in hiring decisions. What need is there? What need are they trying to fill? Are they looking for more subspecialization in a multi-group practice, or within an academic practice, for example? You have to understand what you bring to the practice. Now, again, you're doing your why, right? I'm fired up about this, and I'm passionate about communication. I'm passionate about changing our community, whatever it is. And they're seeing your how and your what, and that's okay. You have to look for this cognitive resonance in that sense. What's in it for them? People are making good business decision. This is a little cynical, but well, it's very cynical what I'm about to say. But when I talk to my fellows, I always say, when you're talking to somebody else about a job, just imagine the other person across the way has their hands behind their ear, listening for how you're going to make them some money. Of course, that's not entirely true. It's about the money is super important, but they're looking for fit and shared values and shared mission, and that's the long-term success. Having somebody jam through some RVUs, that's nice for a little while, but if it's not married to a true teamwork and teamship and trust, there's no legs to it. So what choices are there, in terms of when we look at, if you're in a practice, if you're hiring, if you're looking for positions, what are the key differences between specialty practices? Well, the old cartoonish difference between academic and private practice is really just not adequate to explain these things. More and more, we're seeing folks get attracted to the employed model, and this is these are the big distinctions, in my opinion, about the nature of the practice that we are entering. Whether you're in a practice or folks early in their career, what practices they will be in. Are you employed or are you self-employed? The size of the practice matters a lot. I know a fair bit about otolaryngology and I would almost say the commoditization of some of the work we do. Not necessarily the bigger practices are, that's not necessarily to equate those things, but the contracting that goes with these really changes the choices. Excuse me, it changes sort of the remuneration and how of course people are paid, and then how it doesn't necessarily change how you practice, but the nature of the practice really is dependent. Are you in a 200 person group, or are you in a one person group, in a smaller town, or in a big town for that matter? So I think these are the things that when you seek out, when you're trying to figure out, what is that you want to do with your life, I think that'll be important. And then to what degree we're substantially involved in training. More and more folks are not in the sort of traditional ivory tower and heavily involved with training. Medical students, residents from other disciplines. It's a rich part of our training. Um, the otolaryngology, ophthalmology are huge mystery areas, I think, for a lot of our medical students. They get a week here, they spend 1 week trying to figure out how to use the ophthalmoscope. A little easier to use the otoscope. Well, maybe that's just my bias, but it's really an opportunity to connect with these folks. So when we think of our careers, what we do is less of the traditional academic private practice sort of black or distinctions, and really has to do with the size of our practice and whether we're self-employed or not. So when we make decisions about our careers, I encourage you to think about this. I can't say I'm going to share the essence of this book in one slide, but um, you know, physicians are find themselves either seeking out or are asked to be in leadership roles all the time. When you're, particularly as a surgeon, when you're an ophthalmologist, when you're an otolaryngologist, most of any room you're in the medical center, you're what's going on. The decisions that come from you, in collaboration, healthy collaboration. I'm not saying you're barking out orders right, left, and center. That's not going to work. Um, but we end up in these leadership roles, whether it's because you're in a clinical team or you're on a committee and things like that. For our folks early in practice, or maybe early in training, when you're in the OR and everyone's listening to you, and it's talking about teams, when everyone's listening to your movie review, they're not really that always that interested in your movie review. They just can't tell if you're going to ask for a 3 chromic next. That's why they're paying attention to you. They're trying to do their job. But understanding these teams is important. And the way I like to look at this, it was, I think, summarized nicely in this book, is that despite the fact, it's this very jarring title, patients come second, right? We're always taught patients come first. It turns out that's not exactly always true. But patients come second. What has to do with the essence of medical leadership, to focus on the team around you and let them be excellent in their patient care passion, right? Whether it's your medical assistant, your surgery scheduler, your junior partner, that focus on their success as a leader of your team and take care of the people, and the people will take care of the patients. And that's what this has to do with. So who are they, right? When the people are hiring you, I made that sort of cynical reference to, people looking to find people to make money. Understanding the they of, a group you may connect with, whether it's societally, organizationally, work, as you're making leadership decisions, I think it's really important to have a good idea of what they're after and what they're up to. One of the better views on this, it came from a guy named Dave Logan. He was not the only author of this book, but we'll be talking about a book called Tribal Leadership. Before we get to that, one more quote from Simon Sinek, the same guy who wrote Start With Why. It's a beautiful quote, really. A team is not a group of people working together. A team, it's a group of people who trust each other, and that's powerful, right? Because it's about the trust. You can clump people together and they're going to get a task done, but they're sort of, are they really a team if they don't truly trust each other? Okay, I mean, it's arguable, but I think this is a good way of looking at this. What can you do to deserve, engender, create, support, trust, as moving forward with the team? This is a chart from Dave Logan's book. It's called Tribal Leadership. And there are these 5 levels of tribal leadership and this view of tribalism within medicine. Ophthalmologists here, or even within ophthalmology, the anterior chamber guys here, and the canal of Schlemm guys here. I'm just making that up. I don't know if that exists, but an otolaryngology, rhinologists are like this, and the head and neck surgeons are like this, and this sort of thing. And I think we find ourselves in this here. You can see from the bottom up, there's stage 1, 2, 3, 4, and 5, and these are sort of the nirvana levels of how we view groups and tribes within organized medicine. It's probably it's not about medicine, but it's how I look at it for this. I think a lot of the times, I think the worst parts of us end up just languishing or living in level 3, where we like what we do. We're proud of what we do. We like our team, but we often find ourselves putting down other people. I'm guilty of this, and it's not my best thing, but I try to aim for this level 4, that we're great and what we do is great. I mean, you can't be kidding yourself. It has to be good. And that's good enough. And you work on getting other people up a little bit, and maintaining, you recognize the quality of other people, you assume good intent. We can't go around getting fooled by people all the time, right? If you never argue with other people, in the medical, complexities of medical politics, you're probably getting taken advantage of, right? You should bump heads with people periodically. You shouldn't seek it out, but you should find yourself in retrospect that you've had arguments with people from time to time. Else you're probably not really paying attention, or you're maybe getting taken advantage of. But in general, you're assuming good intent, and you're maintaining your status as something part of a healthy organization, but recognizing the quality in other people. You don't need to be up by putting other people down. And that's not an easy one for me. I find myself guilty of this from time to time. Those people, those guys, those general surgeons, those anesthesiologists, stuff like this. It's not my best. But I think when I'm as a leader, we keep our heads up. We try to elevate other people. And then when I do these sort of things, if I drift down this list and get down, it brings down other people. It's not good. So this innocent wonderment, this stage 5, this life is great. It's a little much. I don't think I can achieve that, but I do try to hang out in this level 4, so that we have pride in what we do, we have pride in our team, and we assume positives about other people, and that we can group and team up and attack things together. So what are some of the big questions facing our fields, right? We've talked about decisions we make. Well, as we make decisions, whether or not we're mid-career, late career, me, or early career, many of them are not unique to otolaryngology and ophthalmology. We'll talk about this a little bit, and then talk about some personal things, and we'll talk about the reckoning we make for some of the work or the decisions we make in otolaryngology or in our fields. How am I going to get paid? How am I going to run my practice, right? I mean, that was before COVID. That was, of course, a perpetual issue. There's not more money coming into medicine. There is at best the same, and probably less. And I think that's going to be important. And we're going to talk a little bit about data and its value to protecting the value of what we do. Better to provide this information rather than just be told what we can and can't do. Ophthalmology has certainly, had a realization, or I don't mean had a realization, but has been dealing with these, like otolaryngology, challenges to the value of what we do. It's perpetual for all of us, particularly in surgical subspecialties or surgical specialties. How does this all look in the world during COVID and after COVID? I don't know. There's a practice expense, that we're experiencing now that will probably continue long after, these worst parts of the pandemic. In otolaryngology, there's certain specific disease things are related to COVID. I'm ignorant if I know if that's true for ophthalmology, but I'm guessing we're going to, broadly speaking, go back to what we're doing, but it'll be more expensive to do what we do. Workforce is an important issue. We had a real telling event, 2 years events in otolaryngology, like ophthalmology, a popular subspecialty, and we tend to attract really great students. We had 2 years where we didn't quite fill in the initial match within the NRMP match, and we ended up having to scramble. Took about 10 minutes and filled up all the spots. But it really was telling about our fields. And I hope this isn't unfair. I think it applies to our colleagues in ophthalmology too. I can only speak to otolaryngology. We'll talk about that a little bit. Workforce trainee debt is spectacular. It is a perpetual corrosive consideration. When you're hiring your junior partner, he or she has hundreds of thousands of dollars in debt, and how it impacts their decision making, their choices. I mean, it's powerful. I don't. There's no specialty solution for this, but I think it's going to be important to know when we're in small groups. The call is really a tough problem. And if I'm in Jackson, Michigan, and I'm in a partnership of two. Who takes call? It's the guy 30 miles away if you're lucky. And you have to make those relationships. You can expand your practice with physician extenders, APPs, but in some, they're certainly able to take call, but they can't do the things that the physician can do, obviously. So what is the role of the APPs in our practice, particularly as we deal with hiring and recruiting into outside of the urban areas, which tends to be an issue in otolaryngology at least. Won't talk about satellitosis much. It has to do with the academic hegemony of the academic programs into the suburbs. What is the impact of ongoing subspecialization? I wrote here about otolaryngology. I'm guessing it's similar for ophthalmology. I think in the predominantly MD world, this is a little different than the predominantly DO world. But I'm guessing these questions, and I could be wrong, but I'm guessing these questions still matter. Is there enough to do, right? We're training 5 billion rhinologists or a million laryngologists. Is there really that much laryngology to do? Personally, I don't think it's a big problem. There's a great role for comprehensive otolaryngology and for specialty care. And as we make these decisions, I have this, one of my many guilty pleasures is this show called Deadliest Catch. It's been on forever. It's the same show over and over, but I still enjoy it. And, these folks, it's a tough, dangerous job. And these guys are bickering and fighting when the crab pots are empty. But when the crab pots are full, they're all high-fiving and partying, right? And there's a bit of a lesson here, when you have a group, a practice meeting or a faculty meeting or any kind of get together, when you're talking about your practice, whether even you're talking about research or you're talking about clinical care or some hospital committee, it's a very different vibe if there's crab coming over the rail or if there isn't. And it's a pretty basic thing to say, but please don't forget the impact of this as we talk about our decisions. What do things look like in the future? Technology, it's probably going to make things better. Is it going to erode what we do as specialists? Probably. It'll probably change things a little bit. Automated chest X-ray reading is from the scant few papers I looked at. For the abstracts of the scant few papers looked at, looks like there's automated chest X-rays are doing just fine. One of my partners made by the way, note the Star Trek reference here. One of my partners, Randy Bly, a lovely guy, made a smartphone app for medullary fusion detection. You have to have a little coned piece of paper rolled up, but this ain't going back in the bottle. And we are going to do nothing but more and more automation. Now, will it allow us to do other things? That's the question, right? Is it going to really take away otolaryngology? In this case, these examples? I don't think so. I think we'll just do better and better things. My hope is it'll help with triage. One of my former fellows, really super genius guy, Tony Law, down at Emory now, did this programming for a neural network to do audio recordings of voices and to help triage for the presence or absence of a mass, right? Because there's lots of distorted voices out there. And, there's certain things you can pick up by looking at hundreds and hundreds of them that can say, aha, there's a mass here. Now, having a mass doesn't make it more or less priority, but probably a little needs to get up the queue in terms of their otolaryngology visit for a laryngoscopy. So that's more and more. What are some other trends that are coming? Well, you may or may not recognize this. This was a little study that one of my partners did. This is the 15 or so, 20 people at our main practice site. And this is the variability of time in epic, the most common EHR, the time in epic throughout the day. This is spectacular. Look at this. Some of these people are up here 2 hours a day live in epic, and some people are down here 15, 20 minutes a day. Now, what's the difference? These people down here have they might have residents around, or a scribe, or a nurse practitioner working with them. I mean, how long is this going to last? These people up top, they're not going to put up with this. So whatever the good and bad, and I think that's the description, the good and bad of the HR. I think understanding our practices in the future will understand like how we do better with our EHR in terms of just our sanity. Now, the new CMS 2021 rules that came out, shortening some of the documentation requirements, I think that's going to be important and powerful in resolving, or at least maybe making this so it's not so sharp of a graph here. The fact that we spent 25 years on this ridiculous scavenger hunt for stupid things in our notes, still it infuriates me. Since the 95, 97 guidelines, we don't get the time back. But I'm happy to see this change within the CMS rules. But when we think about our future and practices, I think it's important to recognize the variability, the impact of how we do medicine amongst our different people, early career, and also this impacts gender, right? There tends to be, at least currently, it'll change, of course, more people in early career are a higher fraction of our women in our field. I want to talk about this a little bit, only because I think it's a telling example of our field. I don't mean this to be a criticism of the field I love, but it is. I think there's a bit of a recognition here. 2017 and 2018, people freaked out about the fact that in the main NRMP match, 95% instead of 100% of the folks matched in the first swing. They had about 10 or 15 spots empty, and they scrambled and filled them all within that week. And that brought out a massive outpouring of like, it's this, it's that, it's the patient specific, program specific paragraph, all this stuff. And it all went away, right? Within a year or two, they adjusted things. And now otolaryngology is as popular as ever. Did we have a problem finding otolaryngologists? No, we did not, right? How good is it that we have 600 applicants for 300 spots or whatever it is, right? Is that a lot of unhappy people who wanted to be otolaryngologists? I mean, I like the fact that people are applying, I like people care what we do. But when we're driving or concerned about, 5% match, are we worried that it was really going to be 70% the next year? Maybe. But I think it really had to do with a little bit of elitism on our part. I don't mean to ascribe this to my otolaryngology colleagues, or certainly not to my ophthalmology colleagues and the people on this webinar. But who is this about, right? Why were we freaking out? Do we have an elitism problem? I liked walking around when I matched into otolaryngology, knowing that people knew, hey, Merati matched into otolaryngology. He's probably a reasonably okay guy and a better above the average student. That was on my mind from time to time, but again, maybe that's my pathology. But I think we like being in this field that is thought of as competitive, right? So anyway, my point was, I think it had a little bit to do with that, and I think that's why people freaked out. Nonetheless, it was a reminder that we can't take otolaryngology or ophthalmology, I guess you feel the same way, for granted. And this ignited a bunch of student outreach, high school, college, medical student that's working very successfully, and we're continuing to have lots of interest in our field in this regard. This is a slide I showed once at a talk to GI physicians. This is a true story. This is in 2002. And it was me and about 600 GI physicians. I was doing the sort of less filling tastes great debate about reflux being real. It is definitely real, and it does affect the larynx. And just to really shake everyone up, I made this slide up, totally made it up. And I said, well, listen, before we have this debate, because it was debate format, I just want to remind everyone that the mean at that time USMLE scores for GI physicians was 211, and for otolaryngologists 239. And it was crickets. I mean, people were not, they did not find this funny, even though it made up. The panelists, I told them it was a joke, and they laughed. But and I realized they didn't say much. They didn't laugh. It's clearly absurd. I mean, it's like 2 standard deviations. But I wonder if this matches sort of my sense that there was this like, gosh, could that really be true? Right? They seem to be, again, like ophthalmology, it's a competitive specialty that they are a little different. So again, this isn't what matters, but when I bring this up to talk about who we are in the future and how we're going to fill our spots and have our jobs and hire folks into practice all over, recognize that we may have a little bit of an elitism problem in our field. Just my thought. By the way, if you notice that the credit on this one was to Pete Townsend, so it was even more of a lark I put up there. So I put a star on this one. As we look into the future, I think this is the number one most important issue facing the organization, our organization as especially. Um, if you look at our trainees in medical school and residency, they're 50-50 are women. We just don't have the same representation in leadership. The page, in my opinion, has turned. The conversations are happening. Folks in leadership are recognizing, that it takes active energy to foster excellence, recognize these implicit biases that we have and how we got this way, and work on increasing sponsorship and mentorship. My hope as a leader is that I try to keep folks from feeling frozen out of the conversation. There are many, many people who are willing to listen and learn and have a little light shine on this for them. They're just afraid to ask, I think, or almost afraid to be in part of the conversation for fear of getting it wrong or being called out. So again, it's not my revolution, it's not my change, but it's good for my field and it's good for my colleagues, it's good for my friends, it's good for our patients. So that's why I support these efforts. I think it's powerful. One of my favorite things I came across, giving all these talks was this keychain. When we think about women in leadership, after all human history, men should be glad we only want equality and not payback. And that's a reminder to me, you know, I find this to be powerful. I used to call this slide diversity and inclusion in otolaryngology. And I was my buddy, Angela Powell, who's a great leader in our field in New York. She taught me the term inclusive diversity, which I find more energizing. There is substantial underrepresentation of minorities in otolaryngology, particularly African Americans. I don't know the numbers for ophthalmology. Wouldn't surprise me if it was, a similar problem. I don't know. Diversity is an excellence initiative. It's not a fairness initiative, although there's appeal there too. It's really an excellence initiative. It's not that hard to imagine that the future where the patients and the physicians and the administrators and the society leaders share, backgrounds and values, it's not surprising that's probably a pretty good future. That's a good goal. I think that's hopefully where we're headed. It's going to take action, right? It's not just going to take talks and things like that. But, when you're in this, whether you're in your community and you're talking about embracing an opportunity, a new physician, that man or woman, whatever the background is, I think this makes for a better future. When we look, this is a bit dated. I'm sorry, this is the 2018 Academy membership survey that I had access to. Clearly, the membership under 40 is quite a bit different than those over 40. And those are the people taking care of folks. Those are the future, right? They're doing all the membership dues and all the voting and, so getting attuned to this and understanding this is really our best future and not just lip service, right? Inclusive diversity, not just diversity and inclusion, having somebody on the committee. It's progress, but success has to do with inclusive diversity. When we talk about healthcare, and I think this is true for the issue related to leadership and sponsorship, particularly as relates to underrepresented minority, right? We all took a test about this sucker, the Krebs cycle, at some point, probably about 8 times for a lot of us. I was an English major, so I took it like twice, but this is all a big part of medical school, but I mean, sweet Jesus, as important as this is as an otolaryngologist, the chasm of information waiting to be filled about social determinants of health and how these things impact otolaryngology care tonsillitis, acute otitis media with effusion, bread and butter things is yet to be substantially asked or answered. I mean, lights are going on in the darkness, but for all the attention spent on these basic science fundamentals, the next decade is all about getting better at answering these big gap questions in our fields. I think that's going to be really powerful, and it's energizing. It's substantial. It matters. That's a legacy we could be proud of. Where do we go from here? Well, I'm going to talk about a few more things. Subspecialization, I won't spend too much time on this. How much of fellowship training stuff is really, how much of fellowship trained practitioners is really fellowship dependent? I mean, are they really doing a comprehensive practice with a focus in one area? That's probably true for a lot of folks. Is there really a quality control for cases? I don't know. I mean, with some exception, I'll give some otolaryngology examples. Sorry to my ophthalmology friends. Very sort of specific procedures, acoustic neuromic excision, pediatric open airway reconstruction, those are probably more amenable to some sort of regulation or rather organization, not regulation. For a lot of the other fields, I just don't think it's coming. I think we will probably continue to subspecialize more and more, frankly. I'm going to skip that part. And then as we move into the value proposition in medicine, again, here's my Simpsons pitchfork slide. Many of you have seen this number, right? Here's this little brown trickle of physicians and care, providers. God, I hate that term. Down here, and then this massive growth of administrators, was where all the money is going in our fields. We try to maintain, our autonomy or our agency in all this. I think that's a real struggle. And then when you have somebody in leadership for a while, I mean, someone like me, and they say, "Hey, Al, we'll give you this much of your salary to go do this." And I'm like, wow, I could go do coffee and bagels and get surgeon money, and I don't have to get coughed on or sling Epic. I'm in, right? My job is to hopefully be part of the administrative leadership, but frankly, champion the patient care and the responsible, stewardship of this amazing bargain we have with society, that we're so well treated, but maintain the autonomy and respect and exercise excellence and care and be gentle and thoughtful and kind and try to do all these things in the morass of the mill that medicine can be sometimes. Many of you have heard this term, the right time, the right people, right place, all that stuff. What's going to be done where, fewer things in the acute care, tertiary, some things in community-based care, some things in our clinic. When we look at that rise in expenses and so much of it administration, I think this is where the value proposition comes in. There is movement towards population health models. Otolaryngology works okay in most of that. When people see, when the payors see exploding costs and variance, where one hospital is more expensive than the other, this is viewed as opportunity. And this is why we're talking about this. This is what the future is about when we talk about leadership in medicine, in small amounts, in practices, in communities, and in leadership, in bigger organizations. Recognizing the maybe, I don't know this, I fear there's a loss of agency in the greater employed physician model. Is it one physician leader or one non-physician leader speaking for 200 physicians? I don't know how that works, but it does concern me. And when we talk about all this attention on quality, when we're doing MIPS reporting and these other things, quality is the appetizer, cost is the entree. People are focused on quality because it matters. But ultimately, the value proposition is to be about changing the cost of medicine, getting people cared for in the right time, in the right place. And I think that is going to be what we're going to be confronted with. And the only way in our subspecialties, in our specialties, to really confront this is with data. And maybe you've had parallel discussions within ophthalmology, but within otolaryngology, we designed Regent, the registry ENT. I'm not here to sell you Regent, although it is a great thing, I think, for otolaryngology. This great term, data is the new bacon. It's in our case, and there may be a parallel in ophthalmology, it's an otolaryngology designed, owned, driven database for research on cost quality. So instead of waiting for somebody to come tell us, hey, you can't do a septoplasty unless you're under 45 and your whatever, your sleep apnea index is so-and-so. We're going to say, well, hey, here we go. Here's what we can tell you about the quality and the value of what we do. Don't wait for it to come to us. Don't wait for them to knock on our door. Have this data and ask and answer questions of our otolaryngologist's own database. So I think that's been a value. There are some challenges, though. Who will be first to market, or the trough, as I say, and with this pig up there. Um, Otolaryngology was relatively early, and it's going well. I do think there are more and more people buying up this data. This is you and me seeing the doctor, right? This name de-identified data showing up in some database saying if you're an overweight 55-year-old, you probably should get your cholesterol checked or something like that. But in any event, I think this is my challenge when we're in leadership: is participate, be informed, and know what it is that you're trying to get done with this. I think if we in organized medicine within our specialties can be the provider of this expert data and can own this, I think we're going to probably be better off in the future. So I support these moves. The next few slides, I'm going to get a little more personal as we close out. I talked about some of the things facing us in our field. I talked about some of the choices we make in our careers and some of the decisions that go into that. But there's a reckoning for all this. When I spend energy on this, literally right now I'm recording this. My kids are upstairs, getting ready for dinner. They're playing outside right before this. I'm not with them. I'm here. And that's okay. But if I tell people how important this moment is when they're getting their ranger badges at Crater Lake, every yes at work is some sort of no at home. And I don't mean to compare myself to this character. I am not a criminal, at least not anything I know of. Many of you recognize this amazing, powerful, horrible scene at Walter White at the end of Breaking Bad, and he spends this whole just decline into depravity and destroying everything around him. And he constantly tells his family, that he did this for them. He did this thing for them, did this thing for them, and I found myself feeling that way when I'm off at work or whatever. And I say, I did, I don't think I've ever really said the words I did it. I'm doing this for you. But that's what I've imagined, saying if asked, why are you choosing to say yes? And then at the end of all of it, when he's about to die, he comes home to illegally visit his infant daughter, and he's telling his wife, I have one more thing to say. And the wife says, if you don't you dare tell me you did this all for me or us. And he says, no, I did it for me. I liked it and I was good at it. And some of you remember this, but for me it was powerful because it was a recognition that there's so much of us on the inside that drives these choices. It's my life, right? It's your life. You get to pick. And where you put your family and your circle is really important. I'm not here to give any advice. I can't, I don't have that. But for me, it's a trade-off and it's a reckoning. I wanted to live my life with this balance, and there's a reckoning and there's a price to pay for all this. Why do we pursue these leadership roles? Time, extra stuff, the extra patient, the extra clinic. Is it ego? Is it money? Is it the fear of being left out? Is it the delusion of exceptionalism? I must be the only person to do this job. Well, there's also some positive things. It's challenging. I like challenges, and sometimes it's fun. A lot of times it's fun. But I ask myself when I think about that center of that circle, that why. There's a lot of selflessness in all this. You will be judged in how you've helped others. That's what turns me on now. I feel that if the people around me are successful, that's how I will be viewed. And that matters to me. And achieving most day-to-day task things are rarely primary significance anymore to me. They're about other people's success. And building, creating its own reward. I've been able to build one of the biggest laryngology programs in the country or the world here with, we have 5 laryngologists and 9 speech pathologists in a big program. That matters to me. That's what I wanted. That was my legacy. When I'm out of here, I like thinking about that. I'm like, okay, I did this. That was my contribution, for good or bad. I did something. That legacy matters. Going back to that initial slide of the why, there's a price to pay with health, family, friends, money. I wrote this in 2019, I think. This was when I was Academy president, and I'm happy to send it out or to be shared. It was about my own personal journey. In my case, it was about weight. This is me in 2015. I weighed about 370 pounds. I was trying to die, and all the reasons. I mean, I couldn't. I had tons of friends, and I had everything, and it took a lot for me to change. Now, this is a very physically obvious thing, right? Everybody's got some. Well, I can't say everybody. I'm guessing most people have some version of 370 pounds of them, whatever challenges that they're dealing with, whatever struggles, and they're not always visible, of course. Mine was very visible, you know, but it took energy and effort to change. And what changed me, this is just how sick it was. If I think about missing my daughter's wedding, I mean, I would cry because I thought I was going to die, right? 370 pounds, that's a lot, but I didn't do anything. It just made me sad. When I realized, aha, Merati, you think you're the breadwinner, right? That's your thing, right? That's what you want to do with your life. That's how you speak to your family, by providing. And I was, aha, the worst thing that possibly happened to me was if I keeled over or half keeled over. And that's the day I changed. Again, I'm not proud of that mechanism, but man, I lost a bunch of weight and it's still a struggle, um, but we all have these things in us, and so whatever it is, there's a price to pay for these things and why you choose these things and why you lose your focus. So recognize that there is often an unseen hand in your career, and it's fun to be that unseen hand sometimes if you have these opportunities to be in leadership and help bring people along. Gratitude and resilience are synergistic and synergistic forces in professional well-being for sure. I feel super lucky. I have been super lucky. Can you be too nice? Well, people know I'm not that nice a lot of times. So, but I have heard of this from others, that you really should occasionally, it's okay to bump heads a little bit. So, and it gets all back to the first question: what is it you really want from life? So, I think that's important. We talked about who are you. We talked about self-understanding and your career planning, the VD ratio, yes and no, writing out a mission. We talked a little bit of drifted into sort of leadership concepts and what I think is facing all of us in the next few years. As we talk about employment and the value proposition in medicine. And then we're talking a little bit about reviewing the personal price and the cost for the career choices we all make. So it's been my privilege to be here. Thank you very much. I'm looking forward to the question and answer session. Thank you.